Welcome back. Now, prompted by the President's indication of an openness to engage on constructive healthcare reform proposals, the Universal Healthcare Access Coalition has proposed a framework for reform, one that the coalition says is a pragmatic route to achieving universal access to quality and affordable healthcare and designed to work within the country's fiscal constraints. Steering committee member of the coalition, Dr. Simon Strachan, joins us now with more insights on the framework. Thank you so much for your time, Doctor. Let's actually start off with a moment of accountability. I mean, the challenges of the public healthcare system are well documented, but I actually noticed in one of your documents there, the coalition talks about failures and reforms that are needed in the private healthcare system as well. So have all stakeholders as a collective failed to flip the reality that has been plaguing the healthcare system for years?
Yeah, good evening. Thanks for the opportunity. I'm glad you introed it like that. Indeed, we were responding to the President's call. And absolutely, there is definite need for change. And the change needs to happen both in the public sector and in the private sector. And the tragedy of it all is that in the last 17 years, there has been no health reform, not in the public sector, nor in the private sector, despite years of good research, good reports, not alone the health market inquiry recommendations, but the health market inquiry recommendations, which would produce a much more sustainable, well-governed, affordable private healthcare sector, can only be introduced by regulation. And regulation can only be introduced by the government, and that has not happened. So we have now stepped up and said, in answering that call, as healthcare professionals, we got together, and the three leading groups, the South African Medical Association, Progressive Health Forum, and the South African Private Practitioners Forum, have managed to create this coalition that now has 28 signatories across healthcare professionals, healthcare providers, and civil society and patient advocacy groups, who are all supporting the proposal as it stands. This is a living document, and what we've done is produced a strategy framework that will ensure a sustainable, affordable healthcare system that will provide equity of access. But this document is open to anyone and everyone who wants to participate in this living platform to hone this document into something that we all are happy with and that we know will fly, and that realistically any sensible government would look at, grab with hands, and start to implement.
And it's also, I mean, well documented from different healthcare professionals and bodies and associations there that the NHI would absolutely be impossible to be successfully implemented. I do notice the difference between the NHI and this framework that you have presented, that this framework has a more decentralized model. What do the mechanics there look like?
So yes, as you said, the NHI is unimplementable. And what we are looking for is a healthcare system that is affordable and that provides equity of access. So to be affordable, what you need to do is to acknowledge that we have a contributory system, which at the moment is the medical aid system. And you have a public sector. So those who can afford to contribute, in other words, the employed population, would, under mandate, belong to a medical aid. So there would be mandatory cover. And in that contributory system, there would be social health insurance. So there would be a scheme that would make sure that assistance is given to those who are most in need within that group who are employed and funding. Now, what that does is it allows then the public system to improve. It allows the private sector to be governed. And this is the point we were making earlier. We need the public system to improve, not just by funding, but by ensuring that there's good governance, there's good accountability. The decentralizing of it, what that does is it allows the health system to go down to district level. And within regional healthcare structures and in district healthcare structures, the needs of that community can be best met by people in those positions creating healthcare systems for those communities. Now, these are depoliticized, non-political appointments. There is an oversight committee to ensure the people who are put into those positions are the people with the skills to manage it, and that they have sufficient consensus from the healthcare providers and professionals and the community within those areas to deliver what is needed. The pooling of the money and the way the money is distributed through tax, the tax credits would be redistributed, but there would be subsidies. That would be housed at a central level. But the procurement and the delivery of healthcare will happen at the community level. So you'd have a contributory system with the medical aids running as they are, with people able to buy into a standard benefit package across both public and private sector. But you would have a private sector funded person, an employed person, who could go into a government hospital and receive care there, and the government hospital would charge the medical aids and retain the income and develop the hospital. Private medical providers, professionals, doctors like myself, would be able to go and actually deliver service in the public sector. So it's looking at a funding model that requires no extra funds, it requires no extra taxation, which is one of the reasons why the NHI fund is just not affordable. But importantly, what it does allow equity of access to care. And when you've done all of that, and you've got equity of access, and you've got solid funding, and you've got the opportunity for innovation in the system, you've got public hospitals that can become self-sustaining, income-generating, delivering to the people, you then realize the objective that we all talk about, which is universal health coverage. But that's the objective. The vehicle to get there is what we're putting on the table, and we believe that is the vehicle that is sustainable, pragmatic, fundable.
And how do you actually make sure that when making this critical shift in the healthcare system, that there are no disruptions?
Well, first of all, you have to have the will to do it. And the will to do it means that we need buy-in from everybody. And that is why what we're saying is the critical element of this is that although the proposal is pragmatic, the proposal is malleable and it is alive and it can be developed. Okay. So let's create that as we go along. You know, when we meet with healthcare professional groupings, each grouping will say, I offer this level of service. How can I be assured that that will be part of it? Now, each of us in our own discipline can come up with a scope that will say, well, we think that. The point is we need to look at what the country needs. What is needed? We don't need a health economist to come and tell us that this is what a basic benefit package could look like. You could have basic benefit packages that might be different from region to region and district to district. But if this is rolled out with good governance, with oversight, with no political influence, with accountability, you'll reduce fraud, waste, and abuse, and you'll be able to deliver the healthcare that the people need who are within that location, that geographic location that those clinics serve. And this is not hospital-based. Because within that regional system, they can look up and create the primary healthcare system that they need. They can create the allied healthcare system. They can create referral pathways. And there needs to be one national policy on critical care. We need to get this right. Emergency care. If you have a motor vehicle accident on the side of the road, the nearest ambulance to you should pick you up and take you to the nearest hospital. End of story. And that must be funded. And that's what this country needs. So there are many opportunities within this framework for innovation, and that's what I think is really exciting about it.
Just as we wrap up the conversation, Doctor, I say that we need buy-in. So where to from here? Because this framework is now public, because the sooner we put tools to work, the better.
Yeah, exactly. So this framework, as I said, can be done within the current fiscal environment. It doesn't need massive changes in regulations or constitutional predicaments. It is implementable within years, not decades. So this has been presented to the president. This was then forwarded to the Minister of Health in December. And the response that we got when we asked about their perusal of it was, it is being scrutinized, but our response is sub judice. Okay, sub judice, why? This is a brand new proposal.
Yeah.
Sub judice because of the NHI challenges about the NHI Act. We as healthcare providers have said from the beginning, you do not need the NHI Act to effect good, proper, sustainable health reform in this country. So what are we doing? We are telling everybody about it. We are asking everybody to come on board. We're trying to get a groundswell of approval from all the people within the healthcare environment and people public. Patients must know about this. And eventually we hope that whoever the government of the day is will look at this, see the groundswell, and go, maybe we should be paying attention to this and start some level of implementation.
Well, we will be keeping a close eye on the interactions and negotiations and hoping that a viable solution will be found and agreed upon very soon. Thank you so much for your time, Doctor. That was Dr. Simon Strachan, Steering Committee member of the Universal Healthcare Access Coalition.